Hi, I'm Stephanie Zawada, and I am an instructor of neurology at Mayo Clinic. And today I'm going to talk to you about a work that my co-authors and I have published in Mayo Clinic Proceedings Digital Health. And that paper is entitled Real-World Smartphone Data Predicts Mood After Ischemic Stroke and Transient Ischemic Attack Symptoms and May Constitute Digital Endpoints, a Proof of Concept Study.
A very common occurrence following a stroke is the development of post-stroke depression. Post-stroke depression, otherwise known as PSD, develops in 1/3 of individuals who have survived a stroke. In addition, correlations between PSD and functional outcome post-stroke patients have been shown. PSD has established itself as a risk factor for mortality, short and long-term disability, as well as the occurrence of future stroke events. In fact, many individuals suffering from PSD develop recurrent depression in the following years after the event of a stroke. In short, for many individuals that have experienced a stroke, development of PSD can lead to further complications, prolonging their journey back to health. It is important to note that although 1 in every 3 stroke survivors develop PSD, screening for PSD is not a routine practice. One primary complication regarding screening of PSD is the fact that PSD presents itself in a very similarly to cognitive impairment and fatigue, which are 2 other common complications after stroke. Because PSD can present itself in a range of symptoms, a universal tool for PSD screening has not yet been established, and those existing tools are rarely used in common practice. The hope is you can now understand why this lack of screening should be a cause of concern, why it is important to develop a model that can be used in screening post-stroke patients for PSD, as well as the importance of proper diagnosis and mitigating risk factors for those affected with PSD. Now to our research question. We wanted to answer the following question. Can we use smartphone sensors in patient-reported surveys to predict depression severity in ischemic stroke and TIA patients?
So for our proof of concept study, our aim was to investigate whether passive and/or active smartphone data could predict staff-administered Montgomery-Åsberg Depression Rating Scale, or MADRS scores. These are gold standard rating scale scores for depression screening. Talk about measures used in this study. We have the self-reported mood assessments, so those are those PHQ-8 surveys, and the gold standard mood assessment, which is the MADRS scores, and then passive smartphone predictors, so accelerometer sensor, GPS, and screen use data. So our data processing and prediction strategy consisted of a handful of steps. Key takeaway from our study is that when you combined passive sensor data with the self-reported scores from patients, it improved the model accuracy when it comes to predicting clinical grade MADRS scores. And interestingly, as you introduced additional sensor-based, objective-based predictors in those models, the accuracy did continue to slightly improve.
Our research team made the following conclusions. Combined or multimodal sensor models were much more accurate than single sensor models. Active and passive data may successfully triage patients experiencing stroke and transient ischemic attack that are rurally and remotely located for more efficient screening of mood and depression. And finally, real-world monitoring may increase access to post-stroke neurobehavioral and psychiatric care in patients who would traditionally not have sufficient access for follow-up screening, like those adults experiencing ischemic stroke and transient ischemic attack that are remotely or rurally located. Thank you.